Thank you to the organizers for having me. And thank you, sir, for the kind introduction. And thank you to Karthik for sparing 3 minutes because I'll use that 3 minutes extra. So, just to put things into perspective for you, this is 100 years of insulin, right? We are having a session on 100 years of insulin. For the last almost 1.5 to 2 hours, you have been listening to all the virtues about insulin. If you see the list of the speakers, right, and if you see you're the biggest names in endocrinology field talking before me, I'm the last speaker of the day. And also, to put into perspective, the junior most person in the entire list of speakers also. So I'm basically trying to gain sympathy from you. And most importantly, I am debating the most fiercest debater in the endocrinology sphere. So, spare me a few things, right? So when I'm punching about my weight, the best thing actually to do is to change the game altogether, right? So that's what I'm going to do. And, at end of this, there'll be a lot of people who will be angry with me, but, I'm sure you'll enjoy this. And I think this might be something, which will be something different. Okay. So warning, right? Insulin is relevant. This is, you saw this slide somewhere, right? Yeah. So, and always will be, this is what Karthik said, and I agree, right? I don't disagree to that. In fact, I personally believe insulin is relevant, will continue to be relevant, both in type 1 as well as type 2 diabetes. But the question here is not what I believe, but what the world believes. And that is what is more important, right? At the end of the day, I'm not my patient, right? My patient is somebody else, and it's him who has to take insulin, not me. So I think that is ultimately, what my argument is going to be. And my argument, let me warn you, is going to offend some people. So don't take it personally, right? But, take it with a little bit of pinch of a salt, or maybe, a unit of insulin, perhaps. Okay. So, what I'll not do, I'll not talk about newer oral anti-diabetics in pipeline. They'll be there. They will not replace insulin. Neither will injectable ones like GLP-1. Insulin will remain insulin. I'll not talk about oral insulins. It is unlikely to be a reality soon. I'll not talk about smart insulins, other innovative technology. I think you had a great talk by Dr. Bansali, sir. I think, you can refer back to the talk. I'm not going to talk about that. I can never, do better than what sir has done. So, we'll not talk about that. What we'll basically talk about, and my basic outline of the entire argument is going to be this, that we are the people, the doctors, right? We are the people who will make insulin irrelevant. In fact, the argument is it even relevant today? That's the basic argument, right? That's my argument. And, that's the point that I'm going to defend, right? So this is the argument. First, the next generation of endocrinologists, the cream the best of the best in our country, does not find insulin relevant today. I'll give you an evidence for that. Again, I removed the names, but people who have posted this know what they've posted, and please spare me, right, for that. I'll give my email address in the end, so you can send me whatever brickbats you want. So, but this is a post from a WhatsApp group of young endocrinologists, and this debate was initiated by Karthik, not by me. I just put my leg out, and I asked a question, and there's one young endocrinologist who said, I'll prefer sulfonylurea over insulin. Okay, not my words. This is an endocrinologist. Okay, another one. In India, right? I'm just reading it out. This is young endocrinologist. In India, most people who come to you for the first time detected to have diabetes have HbA1c of 11 and 12. No one wants insulin here. You have to give low dose of FCU, which you may later withdraw. Right. So to answer that, I said HbA1c 11 to 12, you must give insulin. Our job is to give the right advice. There's another one who says they respond beautifully to SU with metformin with DPP4 diet and exercise. So, I agree with this, and this is what I'm going to do. Now, Karthik knows this, right? He knows this. He knows who these people are. So I think it's been me and Karthik, but, this is the young endocrinologists who are speaking. These are not, homeopaths or Ayurveds. These are endocrinologists, okay? So, and the younger ones, who are the future, right? Okay. Second argument. The current generation, so this is the future generation, the current generation also doesn't find insulin relevant. Okay, the current practicing endocrinologists, diabetologists, I'll tell you why, again with evidence. So there's a study from Dr. Unikrishnan et al., right? The very famous ICMR Indian Diab study. From this study, some questions. What percentage of patients in this study had HbA1c in the target range of less than 7? Only 30%. 70% did not have HbA1c in target range. What percentage of type 2 diabetes patients? Remember, 70% were not under target. How many of them were on insulin? 3% on insulin alone. Insulin with OAD 8%, total 11%. Out of 100%, only 11% patients were on insulin, right? This is the current reality. Okay, so 30% of patients were having uncontrolled diabetes, but only 11% were patients of were on insulin. So Karthik can say that insulin will be will lose its relevance only when the cows come home or whatever. He may say that, but what he cannot deny this fact, right? This is the reality which we face, right? Okay, moving ahead. This is another study from Dr. Moses et al. Published in Indian Journal of Endocrinology and Metabolism. Right. What was the mean duration of diabetes before starting insulin? 7 years, right? So you have to wait, patient had to wait for 7 years before he was initiated insulin. Fair enough. I'll give it, right? But then what percentage of patients agree to take insulin in the first counseling? Only 10 to 25%. Not my words, study. Okay. We'll now give you my own data. So I just did a quick analysis of our data. What was the mean percentage of HbA1c when we refer to a specialist for diabetes management at our center? We are a quaternary, center where there is no dearth of money or anything, that we don't talk about those things. Yet, the mean HbA1c is 9.8% before they're referred to a specialist, right? First. And then what is the mean HbA1c for initiating insulin in these patients? With type 2, it is 10.1%. It is even worse than the national average, right? So for years together, this is the conclusion. For years together, patients with type 2 diabetes are on treatment. They have not been on target. They have not been referred, and they have not been initiated on insulin, right? Where is the relevance? I mean, there is no use of insulin. Why are we talking about relevance? Okay. Third point. We might be influenced by a lot of things, but our patients are influenced by even more things, right? So what typically influences our patients? A lot of externalities. What influences us? What our patients want, right? So I'll give you 3 case scenarios, real life. Patient with HbA1c 11 on 3 oral antidiabetics. Doctor said you need to be started on insulin. Patient said, I don't want insulin. I will change the doctor. The doctor says, okay, here is another oral antidiabetic. Familiar, right? Scenario 2, HbA1c of 11 on 3 oral antidiabetics. Patient, I've eaten too many mangoes this summer. Otherwise, my diabetes has always been under control. Don't prescribe me insulin. I'll come next time with better control. Doctor says, fine, here's another pill. Scenario 3, patients with HbA1c 11 on 3 oral antidiabetics. I was prescribed insulin by another doctor. I have come for a second opinion. Doctor says, wait, here's your another pill, right? This is the reality. And tell me, Karthik, can you deny this? I don't think so, right? Because you yourself said, this slide, I saw this somewhere, right? From Dr. Karthik's presentation, that money trumps over, science or medicine, right? And this holds true for patients, but also for doctors too. Remember, they have to, also run their show, right? If the patient keeps moving to other doctors, what will the doctor do? And then our patients, and then they are, in turn influenced by external factors. So this is, we had this video. I don't think we'll be able to hear the sound, but this is Mr. Rajiv Dixit. Unfortunately, he's not there anymore. He has 1.3 million subscribers on an unofficial channel. He's an unofficial channel, which is 1.3 million subscribers. And in this video, if you can go to YouTube, you can listen to this. He very categorically says that I will tell you how to manage diabetes, but the first thing is don't take insulin. And then he gives 10 minutes lecture on why you should not take insulin. Now, he's not a doctor, but he has 1.3 million followers on an unofficial channel, right? And of course, you always know this guy, right? So, I mean, Karthik may not agree insulin is irrelevant, and I may not agree, but Baba agrees that insulin is irrelevant. And then Baba completely agrees with this point, right? There's no doubt about it. And what Baba says, Baba gets. That's a reality, right? So we think patients are not influenced by all this, right? You'll be naive to think in India people are not influenced by these things. They are, right? And of course, even going beyond it, right? Now let's see the reality, right? Point number 5. There is a pioneer company which is embedded with insulin. That's all they do. It's a big pharma company which makes insulin therapy. What does this company think, right? They are the pioneers of insulin, right? So a leading pharma company, a pioneer of insulin, prefers to launch an oral GLP-1 analog in preference to their own injectable GLP-1 analog. Why? Right? Tell me why. Because they know that in India, injectable therapies don't work. They know this, right? And if again, it's an undeniable fact, right? You have this, right in front of you. They're very, very gung-ho about this new oral drug, which was perhaps an injectable one, but they didn't launch the injectable one in India. They skipped it conveniently, right? Finally, even if you initiate insulin, do we give it with conviction, right? So, see this study again from Moses et al., right? The difference in mean daily dose of insulin and initiation versus at 26 weeks was 0.8 units, just 0.8 units, compared to, suggesting a lack of optimization. So we do start insulin, but even if we do we give it with conviction? Answer is no, right? So, and of course, you know the guidelines, ad nauseum, as Karthik said, this, you've seen this. And of course, guidelines are continuously sidelining insulin. They consider GLP-1 receptor. This is, ADA says, consider GLP-1 receptor agonist in most patients prior to insulin, right? Trying to make it irrelevant. And again, EASD guideline again similar, right? Finally, let me hit the nail in the coffin. We're discussing type 2, but let me take you back to type 1, where, everybody in this, session will agree that there is no alternative. It's insulin, right? But are the current insulins the best therapy ever, even for type 1 diabetes? Answer is no, because, this is something which, and all of you, I mean, honest, put your, hand on your heart and tell me, no patient with type 1 develops a perfect normoglycemia. They don't. Despite having better, faster, and flatter insulins, right? You don't develop normoglycemia, right? I think, somewhere somebody is really going to, solve the problem of the, the stem cell or the, the other therapies, isolate transplants and all that, right? And they'll perhaps make insulin irrelevant to sometime even in type 1, right? So ultimately, in summary, first, forget the future. Insulin is hardly even relevant today. That's the reality. I think that is what we have to face, right? And I hope at the end of 2 hours of this lecture, this is not the reality, right? I hope things change. Hope there is more initiation of insulin. Hope there is more timely, treatment with insulin. But this is the reality today, right? Second, a standard last choice therapy for all patients. It's a last choice therapy. It is used more as a threat than its actual use, right? This is the real relevance of insulin, right? Insulin continue to scare people. Influencers continue to scare people about insulin, right? Every Baba you take, no Baba likes insulin, right? That's one statement I'll give you, right? And patients, of course, don't want to take insulin. We don't want to give them insulin, right? And even if we want to give them, we don't want to titrate. So this is a challenging scenario, right? Make insulin, so, in words of Donald Trump, make insulin relevant again so that we can retain its relevance in the future, right? And finally, this is the actual relevance in insulin. So as Gabbar said, there's always a threat. Soja wana Gabbar aa jayega, right? What you're seeing is take your pills or else insulin aa jayega. That's the relevance of insulin in today's world, right? So that's my argument. And like I said, if you have brickbats, don't put it up here. You can mail me silently, right? And I'll try to defend it there. But thank you for listening. Thank you.